Hi, welcome to The Cultural Barrier. My name's Bal.
My name's Tej.
This week's episode is sponsored by the National Institute of Health and Research. And I said that all in one go there, so I'm just happy that I said it. Otherwise, we'd have to re-record. This week, we've got a guest speaker from NIHR, who is Helen Winter. Now, today's episode is about inclusion in research, more specific, health research. Now, Helen, firstly, could you tell us what your role in NIHR and what you do as a whole in research is?
Yeah, thanks so much. And absolutely thrilled to be here with you all. And I'm still learning. I have several roles, but my role at NIHR is as a health and care director for Southwest Central, which is one of the regional delivery organisations. So we've sort of recently been branded as the RDN, which is the Research Delivery Network. And it's all about getting research out there to our communities who really need to see benefits and improved health outcomes.
Hello.
So that's what I'm trying to do.
Just jumping straight into it. What is research? Just such a basic question, but I know what research is.
That's a really good question, and one I didn't prepare for, but I really should know. So I think of research as asking questions that really serve unmet needs or unmet answers in how we deliver, how we improve outcomes in our health. So it's looking for new ways of finding how we improve health. So there's qualitative research where we might have more of a discussion and not use numbers and figures, but really get descriptive words about what research or what things could we be doing and what are we looking at to improve people's experience of healthcare, for example. And then there's more quantitative research where we use a lot of statistics to try and find out, for example, whether a new cancer treatment, I'm an oncologist, as if you didn't know by my background, but so we might use statistics to try and see if a new drug is better than an existing drug. So one example of research is our clinical trials, and phase 3 clinical trials are when we have our standard treatment and then versus a new treatment that we don't know if it is better or has more side effects, but we have a hypothesis that that may be better. And so we want to put that into a clinical trial. And obviously, I think also important for people to realise is that research is really governed by very strict code of ethics and the way we practice. It's called GCP, good clinical practice. That means we have to really adhere to ensuring that people are not harmed by taking part in research and that we're absolutely serving them. And I think the other thing to say about research is that it is completely voluntary for people to take part. So in my role, it's about informing people and letting them know what research is and how they might be able to take part, but also being aware that that is voluntary. And in our clinical trials, for example, we're also very clear that if people decide not to take part, it doesn't affect their standard of care, their normal care. We hope we will continue to look after them really well, like we would want for a member of our family. And also that they can withdraw their consent to take part in a clinical trial at any time during that process. So I think it's really strictly governed and has a real ethical protocol behind it, which really ensures that people are safe when they're taking part in research and hopefully very informed all the way through, which includes disseminating, sharing those results. And I think that's one thing that we could do much better as academics, not just write our papers and go to fancy conferences, but actually go back to the people who took part in the research, thank them, acknowledge them, and tell them what we found. And that's one thing I'd really like to do more of.
So on that point, Changing Suits has worked with NIHR on a number of projects. I just want to mention what those projects are.
Please.
Because, of course, our interest has always been looking at inequalities within services, and research is part of that whole scope. Now, we have done a number of events in partnership with NIHR. The first one being raising awareness about research in menopause in the South Asian community. We've done men's mental health in the South Asian community. Taj, you're going to have to help me with others because we've got quite a few. We've got cancer research as well. And the importance of all of those things was actually the South Asian community doesn't really engage the percentage, I'm sure you can tell us as well, Helen, within the research sphere. So one problem that we're having as a community is maybe knowing about research.
Mm-hmm.
I think that's been the top thing in any of the events that we've done, is that people didn't know what research was and that they hadn't been told about it. So if they're not being reached, then obviously they're not accessing and doing taking part in the research because they don't know about it.
So Helen, on that point, firstly, how does NIHR, as well as other organisations, reach the community, not just the South Asian community, but the whole community?
No, I think that is a really important question and sort of fundamental of why research inclusion and why this renewed focus, I hope, I think it's always been there, but a real commitment to saying we must do more inclusive research and ensure that this benefits those people who have most to benefit and outcomes that need to be most improved. And I think it sort of goes before we get to research about building trust and building relationships. And also for many of us who've spent our life in hospitals, not being worried or giving it a go of going out to the community and meeting people who, we may have had different backgrounds and we may have had different upbringings, but actually our commitment to fairness, social justice, and wanting to do the right thing by people, hopefully is a very common theme that many of us in healthcare and in the third sector are striving for. So I think it goes back to building trust and making sure that people do believe us when we say we want to improve outcomes for everybody, and that not making assumptions, not assuming just because I've spent a lot of time doing research, but realizing that hasn't reached people who probably would have taken part. And I think there are many assumptions that are made. And I can perhaps give you one example, because the first time I actually went out of the hospital in my working day was to a marae, which is the meeting place of people, of Maori people from New Zealand. I was working over there. We wanted to do some research in lung cancer because sadly they had much poorer outcomes and died sort of at least 10 years earlier than their white counterparts. So I went to the marae and it was a wonderful experience, but it was a bit uncomfortable because I was used to the hospital setup. I was used to my institution and being surrounded by the machines and the technology. I lived there. I used to pick up the phone and, that was my sort of home number almost. So it did take some courage to actually show a bit of vulnerability in my professional role of going to the maraes. And what I hope that I really learned was about cultural sensitivity and competence, and also that it is on me to learn about that culture, not for them to teach me. And what I learned was wonderful, because people were very welcoming. They wanted to get to know me as a person. They wanted to know why I wanted to do this research, and they also wanted to make sure that we came back and told them those results. And we did that before we did any publication, because we knew that historically that had not been done with many of our communities. And what we were able to do following that was then introduce some Maori navigators into our lung cancer system and sort of have this dialogue between the communities and the secondary care doctors delivering lung cancer treatment, and hopefully break down some barriers there and show that we really were committed to improving those outcomes.
Helen, can I take it back? And this probably should have been asked right at the start, rather than 10 minutes into it, and then people are like, I don't get it. Why is it important that ethnic diverse communities get involved in research? That would be the most important question, I think.
Holding on to ask.
I've been holding on, Why should they be getting involved, Helen?
Yeah, because that is who our communities are. That is who our patients are. That's where our patients and our people come from. So to ensure that the answers that we get from the clinical research that we do does impact on everybody, we need to make sure that people have been represented in that research. So whether that's testing a drug or looking at some genetic factors or looking at people's social and cultural circumstances, that needs to be represented in our trials, so that when we get the results and say a drug does have some benefits, we know that if we introduce that drug into a standard of care, into the health service, that everyone will have the same chance of that working, because we've included them in the research that was done.
I've got so many.
Yeah.
I wanted to ask you, first of all, like COVID was a time that we saw there was a real difference of people being impacted from different ethnic backgrounds.
Completely.
Yeah, like so the Black and Asian communities were more affected by COVID than our counterparts, our white counterparts. So that is why it's so important that we do participate in research. But what is a cohort of participants at the moment who are coming to be part of the research at the moment?
That's such a good question. And every research question has something called inclusion and exclusion criteria. And often those exclusion criteria are on clinical grounds, especially if we're testing a new drug. So it might be that someone's kidney function, or we call it performance status, or their ability to take part in the research is sound. One thing that we have been challenging, and you may remember from the meeting on the brain work that we were doing, is does there need to be an upper age limit for research? So sometimes people have been excluded, particularly historically, on age. And we certainly don't want that to continue, because we're living in an aging population, and we want the results to be generalizable to all of our population. And I think if we're talking about an ethnically diverse population, and we definitely want to have more ethnic diversity in our trials to ensure that the results do impact for all, then it's important that language is accessible, that trust and that historical, some historical concerns about prior treatment, either through the NHS or in historical sort of misjustices. I think we need to work even harder to ensure that there is equity of participation, not just equity of access.
I was going to say, I mean, on that point, in regards to what both of you have actually said, is we need to see what the general public, including ethnic diverse communities, how they're impacted by drugs or procedures. Because COVID was evidence that actually not all viruses affect different ethnicities
in the same way.
Nor do drugs. Drugs differ in the way that they impact different ethnicities. So if we're not at the table and we're not getting involved in research from ethnic diverse communities, then actually we don't know what impact a certain drug will then have when it goes out into the general public.
Yeah. So we're doing a study at the moment. It's a very sort of niche study. It's called the MolGen study, but for anyone who's interested, and it looks at pharmacogenomics, how we and how our bodies metabolize certain drugs. And in the study that I've been looking at is 2 cancer drugs that we've been using for many, many years, but have seen that different people react differently to it. So some people will tolerate it really, really well, and then other people have a really profound reaction, sometimes ending up in hospital, and we certainly don't want that. But this trial is really looking to see, are there a more diverse range of variants that we could test for in standard practice to pick up people who are more likely to get toxicity. And we certainly want to see more people from our ethnic diverse populations taking part in that, so that when we test those drugs in real life, and we have somebody from our ethnic community, we know that if we say the test is negative and that we're not expecting them to have toxicity, then that is a true result. It's not that we're missing one of the variants that we haven't picked up because we've never tested anyone from that community.
Can I ask you something in that case, just from what you just said? If ethnic diverse communities aren't getting involved in research, I'm assuming that many of the drugs that are out there at the moment will be based on white populations.
In which mainly on tested on men as well.
Oh, that's interesting. Yeah. In that case, when people take these drugs, or actually the GP, the consultant may not know what the impact of that drug will have on the patient. And that's not out of, any negativity. It's just the fact that the data just wasn't there.
Yeah.
Is that correct in assuming that?
I think there's a word of caution about that, because I don't want people to think, oh, these drugs haven't undergone proper testing. So they have gone out proper testing, and there will have been diversity in the populations that they've tested on, because many of these drugs have been tested, from around the world as well. So sort of with global populations. And also the kind of reassuring news is that once a drug is then approved, because it's gone through the NICE process, data is still collated about that, of real world data, so that if there are some signals that there are unexpected side effects, they will be continued to be reported. So I think people can still be reassured with the medicines that they're taking. And I don't want people to sort of think, oh, these have not been tested on people like me. But I think, obviously, that is why the research is so important, that people are part of the research. And if people aren't mentioning research, if healthcare teams aren't mentioning the research, then, ask them. We should be, presenting that and telling people what research, but there is be part of research now. And so ask people, what research are you doing for people like me? What can I take part? And again, it's all voluntary, but at least you get the information so you can make an informed decision about that.
That is so interesting, though, because there's so many barriers for everybody involved in the process, where, if ethnic diverse communities aren't getting involved, there's only so much you can do. Obviously, there is a certain percentage. Again, I'm going to do a bit of a difficult one, where, Helen, you probably will have a go at me after this podcast stops recording, but we'll do it nonetheless. Go on. So the interesting thing where you said, obviously, the data carries on being collected once the drug is out there. That's how the world works. You've got bigger populations, got more data to work on. Now, with COVID, as we know, the injections are rolled out very quickly, and I'm going to learn something here. By the way, I've got a background in biomedical science. I've got I understand.
Holding my breath.
I've got certain. No, it won't be too technical, because it's been a long time. But when you said certain words, I was like, oh, I remember when you learned about that.
Yeah.
When the COVID injections came out, there was a fear because they'd come out so quickly. Obviously, what was put out there was actually, it's been in testing for a very long time. And that's when it's come out. However, the impact of perhaps the messaging that went out maybe didn't reach everyone, and there were side effects, and that then sort of propagated that whole thing of where you said we need to build trust within communities.
Absolutely.
And when we went back and did some research ourselves with the communities we're working with, COVID did have a big impact on that trust element with researchers, and whether people would put their names down. Firstly, that whole thing of being aware of research is a massive thing, and it was quite clear from what we were hearing. They didn't know that they could get involved. And there was a lot of interest actually in the meetings that we had, saying, well, actually, how can we get involved? But then it's that trust element, because COVID really did impact not only the virus, but the messaging that went out to communities. So how big is that trust element, and how much are researchers now fighting to sort of build that trust up again, because COVID did have a negative impact on that aspect of it as well?
No, and I think it's absolutely right to bring up COVID, because we know that disproportionately affected people from our ethnic minority backgrounds and South Asian backgrounds. So I think there is huge learning from that, and the sort of inquiry and things are still going through that. I think that was an extraordinary time, and I was part of the recovery study. So we switched some of our cancer research to looking at ways of improving outcomes, and we think that saved tens of thousands of lives. It was done at speed. It was done in a unique way of setting up the trial. But it's really sad to hear that people didn't hear about the research, because that research was happening at the coalface as people were coming in quite poorly with COVID. And one of the first drugs that they tried was steroids, simple dexamethasone, which is, very, very cheap drug now. But we think the inclusion of that, has saved thousands of lives in the UK, and never mind a wider. So research definitely improved outcomes, but I think the messaging and that building of trust, we need to start sort of earning people's trust again, and putting our hands up when we don't get things right. And I think that's sometimes quite hard for some of us to do. But I think that's why we want to build that relationship with our community groups and say, we haven't got all the answers, but we are committed to improving outcomes for health for everyone. And also, many of your community have the research questions they would like us to do. So actually asking them, what are the ideas that you have? And back to the people on the Mirai, we were doing some qualitative research asking about biobanking and molecular testing, genetic testing, which was just coming into the sort of place in lung cancer. And one of the things that someone said to us was, well, if you look after yourselves, promises you'll look after yourselves, so you will look after our tissues and do the right thing with the research and the trust that we are showing you. And I've never forgotten that, because it can be tough. Not as tough as, of one of our patients, but it can be tough. And I just think we actually owe it to our communities and to the people that we serve. And we're very, very privileged. I feel very privileged to be a doctor and in this role. But there is a sort of societal contract that comes with that, and say, I absolutely am striving to do better. And I certainly haven't got all the answers, but we are listening, and I hope that we will put our hands up when we're not doing well enough. And as I said at the beginning, I think that disseminating our results or sharing those results back with the community is something that we hear is hugely valued. But I think we could be doing that much better. And we were talking before we started recording about the meeting that we had with our young or our early academics, and that early engagement with our population and our communities to get that sort of shared research question, but also about going back and acknowledging that relationship. And it wouldn't have been possible to do that research without that partnership.
So with the clinical research that you do, there's phases to it, isn't there? Rather than just going straight in there and then just testing a drug. It isn't like that. There are testings that are done in different phases. What are the phases that you go through to get it to a clinical point where you're okay, it's not going to all go, all over the place, because there has been like things that have been put into place, and it's just that last bit of actual clinical testing that you're doing.
So much of the research that we are talking about people can take part in is not about drug testing. So drug testing and finding new treatments and these phases of these clinical trials for drug testing is only one, smaller part of research. It's important in things like cancer, because we're always looking to find new drugs, because, we want to improve who's living longer. So in cancer, when a new drug comes, and sometimes it's not even a new drug, it might be an old drug that we've been using for something else, but now we're saying, does it have a role in this situation? A bit like the steroid during COVID, that we've been using steroids for lots and lots of different conditions, and we knew it had anti-inflammatory effects. And then some very clever person thought, I wonder if something as simple as dexamethasone might reduce some of that inflammation that we knew caused some of the respiratory, really severe reaction. So sometimes it's a new drug, and like a vaccine, as you were referring to, and sometimes it's a repurposed drug, or a drug that we've got lots of experience over here, but now we want to say, can we use it in this setting where we're still seeing that we need to improve things? So I think that's, quite nice, that repurposing of drugs that we're very used to. So we certainly see a lot of that in our cancer and in other medical conditions.
And at that point, you would have known the side effects, because it's already a drug.
You already know, exactly. So you can warn people and know that. But when a new drug comes along, it's sort of put in we call it an early phase trial, often where it's actually given to healthy volunteers. So when we had the COVID vaccine, I was actually recruiting some of our health workforce to take part on healthy volunteers to see how this drug was tolerated, hopefully to see whether it would reduce the chances of getting COVID. But that early phase is actually to make sure that it is tolerated and the side effects aren't too difficult. And then you move into the next phase where you're testing the drug on people, perhaps with a condition, or perhaps not purely healthy volunteers, but a more representative population, and just seeing what the drug is doing to to the body, and what, for example, in cancer, is there any response? Are we seeing any responses? And then we move into that much more established phase 3 randomized control trial, where we're testing this new combination or new drug versus the old drug. And sometimes people are, that not all of the treatments are randomized, but a lot of those trials are randomized, and people think, that's very strange that I can't choose, and the doctor can't choose whether I get the old treatment or the existing treatment or this new combination. But that is to ensure that we reduce any sort of, we call it selection bias or bias, to make sure that any true results or any true improvement we know has come because there is an actual improvement, not because we've chosen who had one arm and who had the other. So that's why sometimes people are asked to take part in a randomized control trial. And certainly in my clinic, we spend a lot of time talking about that. And some people decide, I don't like the idea of that. And other people say, well, I'm going to at least get the best standard drug. And then there's a chance that I might see what this new treatment's about. And sometimes it's even blinded so that people don't know which combination they're getting, the standard one or this new one. And sometimes we don't know, so that we don't bias our reporting and saying, oh, we think those people on this new combination did better. So it is quite complicated. And that's perhaps sometimes why we assume that some people won't want to take part or don't want to hear about it. But we very much want people to know about it and have much more transparency in what we're doing, because this is why we're doing the research, to improve outcomes.
And when you get the side effects, I've got so many questions. I'm like, holding myself, I'm so interested in what you're saying.
I know you're not letting me in. I was like, I've got a few questions, but I'll stop talking. Go for it, Tag.
When you see the side effects on in a packet of drugs or anything, it's not something that, is it just every side effect that is reported? Because sometimes you look at, and I have often say to people that are going to take some sort of drugs or whatever, don't look at them all. That is going to put you off, because it's very likely that it won't happen. Is that true, or have I just made that up and just?
No, I think it's a really, really good question, and I like the fact that those side effects are listed, because I think forewarned is forearmed. So if you know what to look out for, then you can monitor yourself, because no one knows your body better than you. And so I'll have patients say, I really think that new tablet isn't working for me. And, and we have to trust people as we're asking them to trust us. We also trust people to say, well, actually, if it's a new blood pressure tablet or something else, we can say, well, there are alternatives. And that's the nice thing. There are other options that people can have. So I think it's good to be informed. So I think it is good for people to read those. And certainly in a clinical trial, because of this informed consent and this ethics, we absolutely go through everything that might happen. So, and sometimes that can sound quite scary. But again, it's saying, we will look after you. We will monitor you very closely. We do lots of blood tests often when we're trying new drugs or new combinations, as we do when we're giving standard treatments like chemotherapy and immunotherapy anyway. So I think it's good for people to know what to look out for. And then if something isn't suiting them, they let us know.
I just want to, there was a meeting that we attended. I hadn't realised because I was online just a few weeks ago. And I am going to compliment NIHR after we've done this question, because I think that the work that NIHR are doing to make research inclusive, we've not seen, we've only been around for 4 years, worked with a number of service providers. The work that NIHR are trying to do to get into the communities is amazing. I think there's very few organisations that we've seen that are doing such a good job trying to engage communities, because sometimes on the flip side of it is actually we feel like it might be a tick box exercise. And me and Taj have had this conversation where actually NIHR are really trying their best. We've done not only those projects that we've been discussing, but again, also in universities, people that are new researchers, having us on to discuss what we learned from the communities and feed that back to researchers as well. The other thing that we did actually with yourselves was look at funding applications. Were they inclusive funding applications?
Absolutely.
Again, we never sat on a panel where they even cared about it. So I have a lot of respect for the work that NIHR are doing, which is fantastic. That wasn't my question.
No.
That wasn't my question.
I've got a question in there as
well. I thought I was going to relax then for a moment.
No, that was false sense of security, Helen. I was trying to speak after the question, but what I was going to say was actually it's not just drugs, like you said, where research takes place. It's actually data as well as procedures. I mean, something NIHR showed us was procedures when you're about to give birth. There's different ways rather than using the
absolutely,
which again would fall into the whole of research work. One thing I did say at that meeting, going back to the point of this, part of this conversation, was actually I have been involved in research. And I had said at that meeting I hadn't, but when I came off the call, I was like, hold on. Yes, I have. And not only was I involved, but I had taken my mum, my dad, who live in East London, and my mother and father-in-law, and father-in-law. So there was a car full of us going to this research centre. And it was to help. The research aspect was looking at heart health.
Yes, brilliant.
So actually, the question as to why a whole car full of us went and did it was we were going to get the general health checks done and a booklet to tell us exactly what that meant. Going back to it, that feedback of, well, actually, as a community, yes, we know in the long term we're helping a whole community out there. But in the short term, and I suppose the selfish aspect of it, the reason we went was to get that booklet and see what health those general data meant. What other sort of reason would people want to get involved in research?
Important question. And I think it varies for everybody. And I wouldn't want to even assume why different people have done what they've done. Certainly, some of our Maori people and communities, there was a concern at the time about asking about genetic testing and different things. And we were sending the samples away to Australia. And there was an assumption made at that time that might not be something that people from that community would do. But what they told us is if this will help future generations, of course we want to help. But we want it to be done in a culturally sensitive and we want to make sure, as I said before, that you're looking after yourselves so that you really look after our tissues. And we actually called it Keep My Tissues Safe because they were entrusting us with that. So I think there are altruistic reasons. So we've certainly done some research in Oxford where people weren't actually getting any benefit for themselves from interventions, actually, but they still wanted to take part, because somebody had explained the reasons and also were going to share the results back. So they felt part of that research. So I think there's so many reasons. I think for individuals, certainly the people that I see that are taking part in the research, I think they get exceptional care. That is what I would hope, that anyone coming to the NHS, I would hope gets exceptional care. But I think people taking part in research really do get great care because our research teams are motivated by doing the right thing and pushing the boundaries and trying to discover how we can improve people's outcomes. So we made a video some time ago with NIHR on a patient, and the video is still around, and I will never forget him. And he had pancreatic cancer, sadly, had a very poor prognosis, took part in a new drug trial, actually did really well, but he shared his story and made a video in a very vulnerable time in his life to say that he felt that not only did he feel that he was getting some clinical benefit, but much more getting some putting some purpose and giving something back. And we learned so much from him and his amazing wife as well. And I'm often thinking of them when I'm in the clinic, and particularly as we're striving to improve outcomes, particularly for less survivable cancers. And now with the National Cancer Plan, there's a focus on rare and less common cancers, and pancreatic cancer being one of them. So I think some of the people who take part because a family member or their community is more affected. So that might be diabetes or cardiovascular disease and stroke. So I think the reasons are really, really varied. And I think many of our community are really interested in science. And perhaps science wasn't done very well at school or didn't really have that science background. But actually the science and the way we conduct the research is fascinating in itself, as well as, I hope, that the care and the attention that people receive. And I think I hope people would feel that care, which is really bounded by those strong kind of ethical principles of do no harm and making sure that people are informed every step of the way about why we're doing that research. And that may include research that actually ultimately shows that it didn't have any benefit. Doing something extra wasn't any beneficial, but at least we had looked and then we've been transparent about that answer.
Can I just add, I mean, research is really interesting because I think you sort of hit the nail, for me, you hit the nail on the head. If their family members are going through anything or you know someone, that is a massive thing, because even in our own situation, where, you know, the population is aging, there are more chronic disease, long-term diseases.
sure.
So now is a really important time that we do get involved. I mean, we've had personal circumstances where desperation has meant that actually we do want that research to happen and it hasn't happened. And that's another part, you know, how far can we go before actually we should have got involved earlier? Just one more thought before we come to the end. What has changed, going back to that trust element, because, you know, we're talking about the communities who have been through a lot politically, have come from different countries, they've got the whole colonization aspect, and that did impact research quite drastically as well. How much change has come over the decades to make sure that trust is built, and how much more work are organisations like NIHR doing and other research organisations doing so that we continue to build that trust and make sure that communities know that communities are safe in their hands?
I think that is the absolute fundamental of it, and that is research inclusion, ensuring that everybody, whatever their circumstances and wherever, you know, they are in our country, they have that ability to access equity of care, first of all, and then also that we are really committed to exploring questions and research that will say, are we happy with the status quo? Are we happy that many people are dying way before others and that life expectancy is not equal for our communities? So, and I think there is a real commitment. I'm glad that you mentioned what you have felt and what you have seen. And I think there is a commitment to say we have not been as inclusive in the past as we absolutely need to be now. And I would draw, there is a framework now for addressing health inequalities called Core 20+5, which really looks at targeting people from the most socially deprived areas and those people from, we call it inclusion health groups, but actually people who've really been excluded in the past, whether that's from our homeless communities or rural communities or people from ethnic minorities or people whose first language is in English, and say we absolutely need to have equity of access to healthcare and world-class healthcare to start with, but actually equity of the choice to participate in research. So that if there is a research question about a certain health condition or a certain set of circumstances, that is made accessible for people, and then people can make their own decision. And having a conversation about research doesn't mean you're signing up for research. It means that you know a bit more. And then there might be another research question that fits much more with your circumstances. And you'll say, well, I didn't want to do that research, but I actually would like to look at that research. And you mentioned desperation, and I'm really sorry to hear that. And obviously that's something, I have seen in the past, that people have been just desperate to improve the health, particularly of a loved one. And we don't want it to get to that stage. We want to have more choices and more options. And the only way, I believe, that we can improve sort of really meaningful improvements in survival is to offer more research opportunities. There's lots of things we can do, in the service and the way we deliver our healthcare, but actually to push the boundaries and say, how can people live better quality lives, have better life chances, and have better longevity and length of life? Let's do more research. And it isn't really just about who's in the data and who's in the research, but it's about how is that discovery going to benefit everybody and have real impact. So it isn't just about getting more people from a diverse background. It's saying, how does that then reach those people?
Perfect. And a final question just before we finish up. If someone is interested in getting involved in any research, how can they do it?
Yeah, so the NIHR have a program called Be Part of Research, but it's also something that all healthcare professionals know about, whether they're active in research or not. So we can share some links with yourselves, but do ask. And if people say, well, we're not doing research in that area, well, say, well, why not? And if you want to do that, or someone that might be interested, let's take part. So there are a lot more now public and patient engagement and involvement groups who are really hopefully designing research from a much earlier stage with researchers. So we do want to listen and hear from you. And if you've got an idea for research, no idea is a silly idea, because there's so much improvements that are needed, and we want it to come from the very people we're trying to serve.
Perfect. Thank you so much, Helen. That has brought it all back to me and really taught me so much more, because things have changed so drastically over quite a short period of time as well, actually. But thank you for coming on, and we look forward to continuing our work with NIHR, because we do actually think it's a fantastic organisation.
No, that's great to hear. And as I say, our work will never be done, but we are listening. And if anyone wants to be involved, please get in touch with us, and we can share some links, I'm sure, on your website.
We will do. We'll share those links. That's goodbye from me.
And goodbye from me.
Follow us on Instagram and Facebook, changing_suits, and subscribe so you never miss an episode.